Sympathomimetic agents and anesthesia practice. We will be reviewing the pharmacologic class of sympathomimetics and taking a deeper look at the agent ephedrine. The term sympathomimetic breaks down simply to a drug which mimics the activity of the sympathetic nervous system, the fight-or-flight division of the autonomic nervous system. Drugs in this class can also be referred to as vasopressors or vasoactive medications. The topics presented will include characteristics of sympathomimetics, their mechanisms of action, uses and contraindications, and side effects a patient may experience. Ephedrine will also be discussed regarding its agent-specific characteristics. Sympathomimetic agents can be non-synthetic catecholamines, synthetic catecholamines, synthetic non-catecholamines, or non-catecholamines. Despite differences in their chemical formulary, sympathomimetic agents stimulate G-coupled protein receptors through direct action, indirect action, or mixed action to achieve vasopressive effects and central nervous stimulation. Direct-acting adrenergic agonists mimic the action of endogenous catecholamines, which include epinephrine, norepinephrine, and dopamine, to directly bind alpha, beta, or dopamine G-coupled protein receptors. Indirect-acting agonists also stimulate adrenergic receptors, but by a different mechanism than their direct-acting counterparts. They stimulate the release of endogenous catecholamine stores from presynaptic vesicles, or prevent the reuptake of those endogenous catecholamines from the synapse for reuse and repackaging into synaptic vesicles. This will increase the synaptic concentration of catecholamine available to bind the adrenergic receptor. Mixed-acting agents combine the indirect release of catecholamine or inhibition of reuptake and also directly bind the agent to the adrenergic receptor. Individual adrenergic G-protein coupled receptors can be subclassified into alpha 1 and 2, beta 1 and 2, and dopamine 1 and 2, each with a somewhat unique anatomic area of receptor density and physiologic activity. Stimulation of the receptors by sympathomimetic agents or endogenous ligands causes a conformational change and activates a second messenger system. The second messenger system will activate or inhibit processes within the cell, followed by a process of signal amplification to speed the response. This graphic offers an abbreviated review for those who may want a review of the sympathetic nervous system receptors, their sites of action, and their response to stimulation. Alpha and dopamine adrenergic activity is further depicted in this graphic. Lastly, you'll see that beta adrenergic activity is further depicted here. A deep understanding of each receptor site and effector organ response is essential to understanding the sympathomimetic you may choose based on your patient's presentation. To prevent excessive adrenergic receptor stimulation and therefore end organ stimulation, catechol O-methyltransferase, also known as COMT, or monoamine oxidase, MAO, metabolizes excessive catecholamines and terminates their effects. Sympathomimetic use is common in anesthesia practice to treat hypotension, bradycardia, and associated nausea and vomiting. An off-label use of indirect agents is in the treatment of postoperative nausea and vomiting, as decreased cerebral perfusion may be a causative factor. Sedation is also a desired effect of alpha-2 agonist use, and bronchospasm can be attenuated with beta-2 specific agents. Agent choice is based on therapeutic goals and clinical judgment surrounding the patient-specific factors. Few contraindications to sympathomimetics exist, as the risk of circulatory collapse greatly outweighs the risk of unwanted drug effect. Patients should not be given agents if there is a known hypersensitivity to formularies with synthetic compounds. Myocardial sensitizing inhalational agents such as halothane and cyclopropane can precipitate arrhythmias when combined with sympathomimetics and are therefore contraindicated. Relative drug interactions include MAOIs, TCAs, psychostimulants, and cocaine, as they may have either a diminished effect or an exaggerated effect based on chronic or acute use. Combination with oxytocic drugs also may exaggerate hypertensive effects of sympathomimetics. Sympathomimetics are contraindicated in disease states with hypertensive pathologies, which also includes pheochromocytoma and thyrotoxicosis, as the combination may result in extreme hypertension. Disease states such as vascular insufficiency, urinary outflow obstruction, and closed-angle glaucoma may also be exacerbated with sympathomimetic use. While it is not contraindicated, you should always remember that sympathomimetics are additive in effect. A patient may require more than one, but extreme caution should be used in those instances. Side effects of sympathomimetics reflect overstimulation of both the sympathetic nervous system and the central nervous system. We're now going to narrow things down to ephedrine, which is also known as Acovaz here in the United States. Ephedrine is a synthetic non-catecholamine sympathomimetic. It's indirect or mixed acting at alpha and beta receptors as an agonist. Its receptor affinity is greatest for beta 1, then beta 2, and alpha 1. Alpha 2 and dopamine activity are either unknown or there is no activity present. It is also classified as a central nervous system stimulant. As an indirect or mixed acting non-catecholamine sympathomimetic, ephedrine increases synaptic norepinephrine levels by competing for reuptake by the norepinephrine transporter into the postganglionic neuron vesicles. Synaptic norepinephrine is then able to bind adrenergic receptors on effector sites to potentiate the desired sympathetic nervous system effects. Ephedrine also binds adrenergic receptors directly. The effects of ephedrine directly reflect its receptor affinity for beta 1 most, then beta 2, and alpha 1. Beta 1 receptor affinity causes increased dromotropy, chronotropy, and inotropy, and the renin-angiotensin-aldosterone system activation. Beta 2 receptor activity will cause bronchodilation and venodilation, while alpha 1 causes vasoconstriction. It is a less potent but longer acting agent when compared to direct acting agents. Ephedrine is used to treat anesthesia-induced hypotension with or without bradycardia. Anesthesia-induced hypotension is hypotension induced by any inhaled or injected anesthetic medication, including medications given by neuraxial technique. Postoperative nausea and vomiting treatment is also an off-label use of ephedrine. Before treating anesthesia-induced hypotension with ephedrine or any other sympathomimetic, hypovolemia should be corrected first. All populations should also receive the lowest possible dose to achieve the clinical effect desired. Ephedrine doses can be repeated every 5 to 10 minutes to the maximal total dose given in increments. The user should be aware that tachyphylaxis is a characteristic of ephedrine, which means that repeat administrations of ephedrine will be at higher doses to achieve the same clinical effect. A pediatric patient experiencing anesthesia-induced hypotension can be given 0.1 to 0.3 milligrams per kilogram intravenously, with the maximum per dose being 25 milligrams. A maximum total of ephedrine can be 50 milligrams for a pediatric patient. In the adult and adolescent, 5 to 25 milligrams intravenously or 25 to 50 milligrams intramuscularly or subcutaneously can be given to treat hypotension. with a maximum total dose of 50 milligrams. For postoperative nausea and vomiting, ephedrine should be given at 0.5 milligrams per kilogram intramuscularly. Ephedrine is a longer-acting, less potent sympathomimetic agent than direct-acting adrenergic agonists, with an onset that is immediate when given IV or 10 to 20 minutes when given intramuscularly. It peaks within an hour with a duration of action for about an hour. It slowly undergoes hepatic deamination by monoamine oxidase and is renally excreted based on the urinary pH. The average half-life elimination is 3 to 6 hours, with a more rapid excretion based on a urinary pH that is acidic. Contraindications to the use of ephedrine are nearly identical to that of the sympathomimetic class. Patients with a known hypersensitivity to ephedrine or its components should not receive ephedrine. Patients receiving myocardial sensitizing inhalational agents should also not receive ephedrine. Patients taking monoamine oxidase inhibitors, tricyclic antidepressants, psychostimulants, or cocaine may have an absent or decreased response to ephedrine based on tachyphylactic properties. Oxytocic drugs may also exaggerate the hypertensive effects of ephedrine. Patients experiencing hypertensive pathologies or disease states associated with hypertension, such as pheochromocytoma or thyrotoxicosis, should not receive ephedrine. Other disease states are more relative contraindications, which include vascular insufficiency, urinary outflow obstruction, or closed-angle glaucoma. Side effects of ephedrine include sympathetic and central nervous system overstimulation. Ephedrine is also associated with tachyphylaxis, which is when the response to doses of ephedrine decreases with each administration at the same dose as endogenous catecholamine stores are slowly depleted. Doses will require incremental increases until clinical effect eventually ceases. Ephedrine will remain ineffective until endogenous catecholamine stores are replenished. Patients with hepatic failure require no adjustment for the use of ephedrine. It should be used with caution in patients with renal failure, as it is excreted based on urinary pH and may have prolonged effects in renal failure. It should be used with caution in the elderly, as age-related changes to hepatic and renal function may have occurred. There's also a potential for polypharmacy and drug interaction with the elderly. Ephedrine is classified as a pregnancy category C, as it readily crosses the placenta to reach the fetus. The fetus is at risk for metabolic acidosis and beta-adrenergic stimulation. The mother experiences the risk of severe hypertension and stroke, which is increased if ephedrine is co-administered with oxytocic agents. The mother should be educated that ephedrine is also excreted in breast milk, and the neonate may be exposed to ephedrine. Phenylephrine has now become the drug of choice for anesthesia-induced hypotension in parturients, as phenylephrine causes less metabolic acidosis in the fetus. Ephedrine can still be used if maternal heart rate may not tolerate phenylephrine use. Please see the following references for any further clarification of the information discussed.